My thesis project is on generalization between verbal operants within discrete trial training implemented by parents. The rise of autism and the need for intervention. So, autism spectrum disorder, it's a neurodevelopmental disorder that affects social communication and social interactions. Currently, the rates are said to be 1 in 68 children. There are many different treatment options available. There's a study done that looked at 111 different options that parents use. However, the most effective option is applied behavior analysis. And not just using ABA, but early intervention in particular is very strongly recommended and has shown kind of the most positive outcomes. A component of early intervention is that parent involvement level. So, a number of studies, Neef, Ozanoff, and Cathcart, have shown that parent involvement has a strong impact on the child outcomes. So, in the Ozanoff and Cathcart study, they had children who were in an early intervention program, and then they provided a parent training that was based off the TEACH model, added in addition for some of the children. Those children whose parents received that additional training showed improvements that were 3 to 4 times that of the peers who did not have that parent training component. So, when resources are limited, whether it's financially or geographically or other reasons, parents may have to act as therapists. So, therefore, in order to kind of improve child outcomes, they need to be trained as well. There are many different parent training methods with mixed results. Mahan and Matson looked at a variety of them. Some are just instruction, some involve some modeling, some are group based, some are individual based. So, how do we really develop effective parent training? Miller and Sloan looked at training parents to kind of modify antecedents and consequences. They did it during a snack time to increase speech sounds. And so they used instruction and feedback, but then when they looked at other times of the day, the parents were not necessarily using those strategies then. They were only using it during the specific snack time in which they had been trained. So Tarbox, Wallace, Penrod, and Tarbox looked at doing a 3-step compliance protocol with parents. They used instruction, modeling, and feedback. And they were able to show that parents were able to implement it across kind of a couple different behaviors to get compliance. So not just on the one behavior that they had trained, but on a couple behaviors. So the research has shown that it's not just a single component training. There's definitely a multi-component training package that is needed. So this research has led to the development of behavioral skills training. Behavioral skills training includes instruction, modeling, rehearsal, and then feedback. There's been a number of studies on it looking at training staff, particularly training parents. Sturmy has done a lot of the work on this, see him with a variety of partners, looking a lot at staff training and then some at parent training. They've done it for things outside of the developmental delayed population, such as teaching gun safety to children, fire prevention. They've looked at how to use behavioral skills training to decrease food selectivity as well. So one of the limitations in a lot of the research is the ability to generalize. So those generalization needs within parent training are especially important. Stokes and Baer recommend that generalization be specifically programmed for within any training package. Yet we don't often see much in terms of generalization probes or even really a focus on generalization in the research. So there has been kind of 2 components that have been looked at. So there's generalization of the treatment fidelity. So can we train the parents to implement a program, and then can they use that to implement other programs? And then also the generalization of the child's responses. So if you train a child to mand, are they then able to mand for novel things without additional training? Specifically looking at discrete trial training and parent training, there are limited studies teaching parents to implement DTT. However, discrete trial training is a very research-based component within ABA. So generalization as well within the research is pretty limited. So they've probed, if you can label an item, can they generalize it to the parents generalize the protocol to labeling another item. So just an additional targets. One of the Sturmy research did look at can they generalize to another imitation skill, so a motor skill to a vocal imitation skill. And overall, research has shown positive child outcomes when parents are trained to do discrete trial. So Lefkaskis and Sturmy looked at that of, can we train parents, can they implement discrete trial training, and then can they generalize from a motor imitation to a vocal imitation specifically. So the purpose of this current study is to investigate the effects of training parents to implement a discrete trial training program on treatment fidelity, child acquisition, and generalization of procedures to other operants. And these are going to be parents of children who have an autism spectrum disorder and do not have prior training in discrete trial. How we're going to expand on the prior study is looking at generalization from a tacting program to an interverbal program. So the method is going to be 3 to 4 parent-child dyads of children who are 2 to 6, have an autism spectrum disorder, do have some verbal skills, but do have delays in verbal. So they have the ability to echo, but do not have a large functional vocabulary. That have low levels of severe behaviors and are not currently in ABA. For the parents, they have to have not received ABA training before. So recruitment, we're going to post up flyers on some local nonprofit message boards. There'll be a brief initial questionnaire that'll be emailed out for anyone who is interested. As part of our screening, we'll do the EESA, which is the echoic screening, echoic assessment from the VB map to ensure that there are sufficient verbal skills in order to run a tacting and interverbal program. And then any observation for severe behavior. So the setting is going to be at a pediatric therapy center. The experimental design is a non-concurrent multiple baseline. The first day is going to be reviewing the purpose of the study, benefits, risks, consent, the overall procedures. The screening will then occur on that day as well. Day 2 will then happen sometime within a week of that first day. We'll do our baseline training sessions. Baseline sessions will be kind of multiples of 3, and then based on stabilization, and then we'll do the training. We'll go a little more into what the training looks like next. And then we'll do the post-training sessions directly after as well. Day 3 will be about a week after that, and we'll look at generalization to the home setting as well as the maintenance of both the parent skills and the child skills. So the baseline, parents are going to be given a written list with the 10 steps of discrete trial training in the program sheets. They'll be read to them, and then we'll have a target on each one that we determine from the screening. The sessions will be 10 trials of each operant, so 20 trials total, and then there'll be a brief kind of 3 to 5 minute break between the sessions. Parents will be asked to follow each program and collect data for each of them. That'll just be the initial baseline to see where is the parent and where is the child, and do we see any skill acquisition just from that. The training will consist of reviewing the data and describing overall performance, and then looking specifically at what the parents did correctly and what they did incorrectly, and going through that checklist. The experimenter will then model with the child how to run it, and we'll use novel tax so that way it doesn't interfere with the data collection. And then the parent will practice implementing as well with their child with the novel tax. During this practice, the experimenter will provide specific feedback on the components. We will keep doing this rehearsal and feedback until they're able to have treatment fidelity at 90% on the checklist, kind of for 3 consecutive trials. We are only doing the training specifically on the tacting program. We will then be measuring, is it generalized over to that interverbal program. So after training, it'll be 10 sessions, same thing of each operant with about the 5 minute break in between. We will stop after 10 sessions, or if the child reaches mastery for 3 consecutive sessions. General feedback will just be provided after that. The generalization piece from the tact to interverbal will then be looked at by, if the parent's able to get 90% on the tacting program, are they able to achieve the same level of accuracy on the interverbal program, as well as do the child outcomes show approximately the same improvement rate. Then the generalization and maintenance probes will take place in the home setting. The same thing, they'll be given the checklist again, program sheets, and asked to run 10 trials, general feedback, and then we'll do the debriefing and everything after that. A social validity questionnaire will be emailed to them that'll ask if they felt the training was valuable for them and their child. Do they plan to implement discrete trial at all with their child, and are they going to train anyone else? And of course, then any additional comments that they have. IOA will be collected at least a third of sessions for both treatment integrity and just study data. The goal is to get a BCBA who is blind to the study's purpose, so that there is no bias in terms of if they think it's a parent versus a therapist. Video will be taken of all the sessions, and the IOA will be done that way, and it'll be exact count IOA. Here's some mock results of looking at baseline to the post-training as well as the generalization probe. So if that data ends up being what we find, the results show that the parents were able to learn to implement the tacting program with the behavioral skills training model, and the child was able to demonstrate improved accuracy as well. In addition, both parent and child were able to generalize the improvements to the interverbal program and into the home setting, which are both kind of crucial components. Limitations of the study are, although the child outcomes are positive, which does suggest that just social attention that was given for parents did function as a reinforcer, we did not do a formal preference assessment. So it is unclear if there could have been stronger improvements even if a formal preference assessment had been done. And the other limitation is only one parent participated in the study, and so results were only probed with that one parent. We don't know if the child would generalize results to another caregiver, to a novel person, or even to a novel person in a novel setting. So future research ideas are looking at generalization to that novel person and novel caregiver. We taught tacting and interverbal skills. Now, would they be able to generalize them outside of the DTT structure as well? So could they generalize them into NET? And then what would be the impact potentially of training both parents instead of training one? And how would that improve child outcomes and improve the generalization ability? Some of the references, a little tiny I know, but there's a lot of them. And thank you very much.